Thanks for your patience. As you can see, we do electrical glitches, but we're all ready to go again. So, welcome all. My name's Dan Ludman. I'm Director of Turning Point, and it's my pleasure to welcome you this morning for the launch of this year's ambulance report, which is a fantastic project that's been going on for about 14 years in a collaboration between the Victorian Department of Health, Ambulance Victoria, and Turning Point Alcohol and Drug Centre. So this is the nice new glossy report that's available on the website after this talk for free download as a PDF version, and then let us know if you want to order any hard copies. So I'm going to introduce Belinda Lloyd, who runs our population health area, who's been driving this project. And really, it's very exciting this year because this is the first year that we have data that's actually across Victoria, so it includes regional Victoria as well as metropolitan Melbourne. So I'll hand over to Belinda, and she's going to be talking to us around the main findings for the report. Welcome, Belinda.
Thank you very much. So I'd just like to echo Dan's thanks for you all coming along today, and also being so patient with our temporary IT issue there, which hopefully we will have no more problems with. IT is not my strength, I have to say. So just before we get underway, I'd really like to acknowledge the partners that we work with to make this project possible. And it wouldn't be possible to do this work without the ongoing collaboration that we have with Ambulance Victoria, and that's across the whole organisation as well. So from paramedics collecting the data through to the research area, through to IT, across all areas of Ambulance Victoria, we simply wouldn't be able to do this project without their work. I'd also like to just quickly acknowledge Ambulance Victoria. In this presentation there are some very lovely photos that have come from some work that they've done, so thank you very much for providing those to give everybody a little bit of a break from the data. I'd also like to acknowledge the Victorian Department of Health, which has been funding this project since its inception, and that's certainly a very forward-thinking, innovative project to be funded, and it's the envy of the other states, so it's really wonderful to be able to do that. I'd also like to thank the Turning Point team working on this project. This is just a small group of people in our population health team, which has now grown to 24 staff. These people worked on this particular phase of the project, so thank you all. The availability of robust data at a population level regarding drug use and related harms is very limited, and it's particularly limited for ongoing monitoring purposes to be able to identify the burden of harms in the population. Ambulance service records represent an unparalleled opportunity to be able to identify harms in the population and in populations and subpopulations who may be at elevated risk of harm or who may not be captured through other means such as population surveys. Ambulance data has been used to a limited extent historically, particularly in the context of illicit drug use and harms. It offers us an unparalleled opportunity to capture timely data and to be able to report that in a very timely fashion as well. There's also the opportunity to explore patterns of harm that may not be able to be captured through other means such as population surveys. When we're looking at harms, it's very difficult to get information from general population surveys, even for high prevalence behaviours and high prevalence drugs like alcohol. When you ask people about their alcohol consumption patterns and the harms they've experienced, it's very difficult to get that relationship between their consumption and the harms associated with it when you're asking people to recall the last 12 months or their life or the last 2 years. And when we're thinking of lower prevalence behaviours and lower prevalence patterns of drug use, particularly the illicit drugs, but also around pharmaceutical drugs, it's much more difficult to capture those populations in general population surveys overall. And because of the marginalised nature of those behaviours and of those populations, they're much more likely to be missed in general population surveys. It also allows us to address the issue of underreporting in emergency data and other systems where we have data around alcohol and drugs. And we've undertaken recently a linkage project where we've linked ambulance presentations that are alcohol and drug related to emergency presentations and hospitalisations. And we've seen consistently in that data, linking over 5 years, that fewer than 50% of cases that we know are directly alcohol and drug related and related to acute intoxication or the patient being drug affected are coded as drug-related presentations. Generally that's not the case. They're very difficult to capture in those other settings. So the original focus of this study was on heroin at the height of heroin supply in Australia in the late 1990s and the early 2000s, where fatal and non-fatal overdoses were causing significant community concern. However, the database captures a whole range of licit and illicit substances that are involved in presentations. We have data for metropolitan Melbourne available from mid-1998, so we're moving into our 15th year of the project now, which is really exciting. And we have regional data for Victoria from May 2011, so we're now covering the full state. The data are updated monthly with detailed information regarding case characteristics, including patient demographics such as age and gender, the case description and the case nature, police attendance at these cases, the location and treatment information. We undertake monthly data coding and monthly data analysis with reports available to our funder within 2 months of a reporting period. So just to indicate that, at the moment we're working on data for March 2013 and we'll have a report to Victorian Department of Health by the end of May 2013. So it's incredibly timely in terms of identifying emerging patterns of concern around particular drugs. So just in terms of the methods of the project, the data utilised in this project are generated from analysis of data that's extracted from VACUS, which is a clinical information system used by Ambulance Victoria. And excitingly, that particular clinical information system is now being used in multiple states around Australia. Prior to October 2006, there were paper-based records, and so every month we'd receive archive boxes full of patient records, and our coders would manually code off those records. So having the electronic data is fantastic and certainly gives us much more information about those cases. Potential drug and alcohol related cases are identified and extracted from Ambulance Victoria data, and we use an over-inclusive selection criteria. So we want to get potential drug and alcohol related cases, and then it's our coders who go through and identify if a substance is directly involved in that presentation. We discard between 20 and 25% of cases on a monthly basis, but we would rather be overly inclusive in our selection and then remove the cases that aren't alcohol and drug related rather than miss some potential cases. We undertake quite extensive additional programming, data entry and validation to be able to accurately identify and extract specific substances involved in these attendances. So why do we need to do all this additional programming and validation and data entry and analysis that we do? This is because the primary purpose of VACUS data collection is both clinical and administrative. It's not designed for research purposes, and it's certainly not designed for my research purposes. And this absolutely is not a critique of the system, nor of paramedic practice. Paramedics are doing the work that they need to do to be able to treat the patients and to be able to report on clinical outcomes, and the system is designed for those administrative and clinical purposes. But because of that, for our research purposes and the level of detail we need to be able to identify alcohol and drug involvement in cases, there are issues of missing and inconsistent coding for us. So for example, to expect a paramedic to code a particular medication into a drug group accurately every time is not appropriate, given the lack of pharmacist training, for example, and so we need to do that additional work. If we didn't undertake all of the additional work that we do in the coding and the interpretation, the analysis, the validation that we do, we'd miss a substantial number of cases just going on the base coding that we receive. So we'd miss around 54% of cases that were illicit drug related. We'd miss 65% of cases where the patient's acutely alcohol intoxicated, and we'd miss around 80% of cases that are pharmaceutical drug related attendances. So it's a really significant need to be able to do this additional coding to get to the information that's required to really understand alcohol and drug related harms at a community level. So how do we define drug involvement? The attribution of a substance is based on the paramedic's mention of the involvement of these substances. And that's based through the paramedic's clinical assessment, by the patient's self-report, or information provided by others at the scene, and that can be friends, family or associates. So we use all of that information and we work through that information in its entirety and together to be able to identify whether a substance played a role in the attendance. But we have a core question that the coders have to ask of the data for every case that they're coding. And that question is it reasonable to attribute the immediate or recent and not merely chronic over or inappropriate ingestion of a substance or medication as being directly contributing to the ambulance attendance? And so I'd just like to highlight two aspects of that. So we're interested in the immediate or very recent and not merely chronic use of a substance. So for example, if a patient is being attended because they have alcoholic liver cirrhosis and they need to be transported to hospital, if they haven't been consuming a substance in the previous 24 hours, they're not alcohol affected or drug affected, we wouldn't include them in this data. While things like alcoholic liver cirrhosis, we can see that they're caused by alcohol. A whole range of conditions are contributed to by alcohol and drugs, but we simply don't have enough information to make that assessment on the etiology of the presentation. So we're interested in people who are drug affected or influenced by drugs at the time of the attendance. And the other part of this is the over or inappropriate ingestion of a substance. So that means that if a patient is being prescribed a medication, they've used that medication as directed by their clinician, we would not code it. And that's even in the case of an adverse effect from that drug. But if they're using it as it's directed, as it's prescribed, that's not over or inappropriate use. So those are the two key things that we need to look out for when we're coding this data. So the kind of information that we have available is around the drugs or substances involved, and you'll see in a moment that we have a very detailed list of substances that we code for. The geographic location of the attendants, and we routinely report at a local government area and postcode level. And if you have a look at the report online, at the conclusion of this seminar, you'll see that we do mapping at a postcode and local government area level. But we actually have information in terms of XY coordinates. So geospatially, we can map down to specific hotspots in specific locations. We know exactly where the attendance occurred. The type of location, whether it's indoors or outdoors, in a public building or a private residence. And this is very important for a couple of reasons. Firstly, in the event of overdose where there's risk of fatality, being in a private space on your own increases the risk of that overdose being a fatal overdose. So it's important to know for specific substances like GHB, for example. But also in terms of issues of public amenity, local law around public drinking, for example, that issue of public amenity and the impact of drug and alcohol use in public spaces is also something of interest, particularly to local government. We also have information about the time of day and day of week, demographic details of the patient, we have their gender, we also have approximate age where date of birth is not available or date of birth, and also patient past history where that's available, so drug and alcohol use, mental health and other factors as well. We have information as to whether naloxone has been administered and the response to naloxone administration, whether it was effective or ineffective. The outcome, whether the patient was transported to hospital, if they weren't transported, why they weren't transported, so whether that was because they didn't require any further treatment or they refused transport even though further treatment was required, which is a really common feature, particularly of illicit drug-related attendances. Whether police co-attended the case, and other clinical data. So the drugs that we include in this project, it's quite a detailed list. This is the first of 2 pages. So as you can see here, the illicit drugs that we include, cannabis, ecstasy, amphetamines. We also code specifically for crystal methamphetamine as a subgroup of amphetamines, inhalants, heroin, both with and without a response to naloxone, GHB, hallucinogens, and we code separately for hallucinogens such as mushrooms and LSD. We code for ketamine and we also code for cocaine. Importantly, we also code for illicit substances. We code for alcohol, we code for benzodiazepines, antidepressants, antipsychotics, selected anticonvulsants, the ones that are used for psych-related conditions, pharmaceutical opioids, other analgesics, both prescription and over-the-counter, so we can code for simple analgesics like paracetamol, ibuprofen and aspirin, as well as codeine combinations, pharmaceutical stimulants and opioid substitution pharmacotherapies. Now importantly, in each of those pharmaceutical drug groups, not only do we code for the group, but we also code for the specific medications. And that really allows us to drill down into particular kinds of harms affecting particular subpopulations and to be able to explore patterns of prescribing and patterns of related harm. So recently we've published a letter in the Australian New Zealand Journal of Psychiatry looking at alprazolam, or often known by the trade name Xanax, related attendances, so we can actually look at specific benzodiazepines, for example. We've also recently published a paper looking at atypical antipsychotic related harms and specifically quetiapine, also more commonly known by its trade name of Seroquel, and comparing that with other drugs in the same group to see what's happening in terms of increasing harms that we're seeing and how that's driven by prescribing patterns and what's happening in other drugs within that group as well. We're also currently undertaking some work looking specifically at particular pharmaceutical opioids and differences by region and by location, and the harms that we're seeing in terms of particular opioids such as fentanyl as opposed to oxycodone and other preparations. So a lot of information there. In hospitalisations data, in emergency department data, and in most other systems, we can't actually drill down to that level. The only area where we can get information about specific preparations is in coronial data, so they're fatal cases, and that subset of fatal cases that are actually referred to the coroner for review. So we're talking about a very small proportion of harms and a very small proportion of those fatal harms actually going through to a coroner's case. So this just gives you a little bit of an overview. There's lots of information on the page, and there's information within in the summaries that have been provided to you and also in the report. But I suppose the key thing here is to look at the rate. So while we've got the numbers on the left-hand side of each column, the rate is on the right-hand side, and that's per 1 million population. Obviously, the population size in metropolitan Melbourne is substantially larger than regional Victoria. So to be able to compare across locations, we need to look at rates as opposed to numbers. And what we can see here across the illicit drugs that are presented is that the rate is only higher in regional Victoria for cannabis-related attendances than in metropolitan Melbourne. In terms of alcohol and pharmaceuticals, what we can see here is the rate is actually slightly lower in regional Victoria for alcohol intoxication related cases than in metropolitan Melbourne, although more recent data is suggesting that those rates are becoming more and more similar. But what we can see is across most of the pharmaceutical drugs, rates are actually higher in regional areas and substantially higher in some cases. So aside from benzodiazepines, where the rate is lower in regional Victoria than in metropolitan Melbourne, we had higher rates for anticonvulsants, for antidepressants, for antipsychotics, for opioid analgesics, and for other analgesics. And I think the standout number there is in terms of opioid analgesics, where the regional rate was nearly double the metropolitan rate in 2011-2012. This just gives you an indication of trends over time, over the 14 years of data that's available at the moment. And these are just some selected drugs. So what we can see in the top blue line that is going up and up and up and up and up and up and up, those are acute alcohol intoxication cases where no other drug is identified as being involved. And what we can see is a substantial and sustained increase over the past 14 years and a continuing increase. The second line there, the lighter blue line, those are benzodiazepine-related attendances, which have consistently been the second most common type of attendances we've seen over the period. It's not illicit drugs, it's benzodiazepines and alcohol that certainly drive the majority of cases that are attended by ambulance in metropolitan Melbourne. The third line, which peaks and then drops, which is the purple line, that represents heroin-related attendances. And what you can see at the beginning of the graph there is that peak in heroin supply where we had really high levels of overdose and the drop when supply reduced. And while there's been a drop and then an increase over the past few years, heroin-related attendances have remained relatively stable. The bottom two lines, which will be a little bit hard for you to see the legend at the bottom, the green line is for cannabis-related attendances, where we've seen an increase over the past 14 years. And the bottom line there is it represents amphetamine-related attendances, where we've also seen an increase recently. So just to separate out some of the illicit drugs so they're easier to see, because we have a different scale than we have for alcohol and benzodiazepines. What we can see there is a real increase in cannabis-related attendances over time, and also a substantial increase in amphetamine-related attendances. What we've also seen over time is an increase in GHB-related harms, and we've seen a decrease in inhalant-related attendances and ecstasy-related attendances. And that decrease in inhalant-related attendances, it would certainly be really useful to unpick that in the context of changing regulations and changing marketing practices, law enforcement practices and retailing practices around inhalant availability that happened in the mid-2000s. We've seen a gradual increase in cocaine-related attendances, but compared with most of the other categories that we examine, the numbers are still very low. In terms of pharmaceuticals, we certainly see benzodiazepines as the most commonly involved drug in pharmaceutical-related attendances. We have seen increases over the period in opioid analgesic-related harms, antipsychotic-related harms, and also the other analgesics, so the paracetamol, ibuprofen, aspirin and codeine combinations of those. So we are seeing increases in a number of areas of concern and potentially less understanding in the community around the harms associated with these pharmaceutical drugs, the potential risks. So to give a little bit more information around, I think I've gone one ahead, I apologise. A little bit more information about what we've seen in metropolitan Melbourne in change over the 2 years, the last 2 years, 2010-11 financial year and the 11-12 financial year. There's been a 25-ish% increase in attendances related to inhalants and attendances in relation to cocaine, but the numbers are quite small, so we need to be mindful of that. Certainly the headline information and the one that I think most people will be interested in, and in the context of anecdotal reports around increasing harms being identified in treatment agencies and other sites, we've seen a substantial increase in amphetamine-related attendances, and this has been almost entirely driven by crystal methamphetamine-related attendances, where we've seen a 110% increase in the last year alone. And this is of particular concern because in the previous 2 years we've actually seen a similar kind of increase. So from 9-10 to 10-11 we saw the increase being around 108%. So we're seeing an ongoing increase in crystal methamphetamine-related harm, which is certainly of significant concern. In terms of alcohol and pharmaceuticals, we've seen a bit of a different picture. In terms of pharmaceuticals, we're actually seeing some encouraging drops in harms associated with a number of those drug groups. But what is disappointing and is certainly of concern is this increase we're seeing in alcohol-related attendances. And these are cases where the patients are acutely alcohol intoxicated with no other drugs on board. And a 27% increase, given the magnitude of cases related to alcohol intoxication, that certainly represents a significant burden on emergency services and significant burdens on patients and also the community. So I'd like to give you just a little bit more detail in terms of the alcohol-related attendances that I've presented thus far, and I'll give you a little bit more information about those. And in this particular instance, these are cases that, as far as can be ascertained, are caused only by alcohol and no other substances. And these cases are usually related to acute alcohol intoxication or poisoning, but may also involve injuries, and those can be falls, fights, motor vehicle accidents. And we're talking here about acute alcohol intoxication, not being alcohol affected. We also code for alcohol involvement in cases and look at that in terms of other drug groups. And from October 2006, where we had electronic data, we can actually code for alcohol intoxication with other drugs. But here for the time series, I'm just presenting acute alcohol intoxication only with no other drugs. And between 1011 and 1112, there were, this is metropolitan versus regional Victoria. And what we can see here is the characteristics are relatively similar across the two areas. We do see more cases occurring in public spaces in metropolitan Melbourne, in outdoor spaces in regional Victoria. And interestingly, we see a higher transport to hospital rate in regional Victoria than in metropolitan Melbourne, but a lower police co-attendance rate. So as we continue over time and have more information to be able to compare across metropolitan and regional Victoria, being able to further explore the nuances of alcohol-related harms across these different areas will be really important, because we know there are, for example, significant entertainment precincts that really drive harms in metropolitan Melbourne, and there are different factors that are influencing alcohol-related harms in regional Victoria. And in terms of the Metro Melbourne data and the change over time from 1011 to 1112, I'll just focus on some of the significant changes. So we can see here that increase in attendances has certainly been a substantial and significant increase. We've also had an increase in the average age of patients from 37 years to 38 years. And what we're seeing in some of our other data, and when we've linked data across ambulance to ED to hospital, this issue of ageing populations of people experiencing harms associated with alcohol intoxication. And actually the age groups where we're seeing an increase in proportions are the 60-year and over age group, not young people binge drinking. This also raises issue in terms of transport to hospital. So we're increasingly seeing patients transported to hospital who are acutely alcohol intoxicated. And based on that linked data, we've actually been able to identify that the increases have been occurring in head injuries in these populations as well. So we're seeing a combination of acute alcohol intoxication affecting judgment, the risk of alcohol-related brain injury, and also the risk of acquired brain injury as a result of falls and other accidents. So we're talking about potentially more complex patients with higher risk and more complex harms. As I mentioned before, we map at a local government area level, and I won't go into this in too much detail. What we can see here is that certainly the areas with the highest number of attendances for acute alcohol intoxication are in metropolitan Melbourne, and are largely concentrated in the areas that are entertainment precincts and areas that people will travel to on a Friday and Saturday night to consume alcohol. However, we see quite a lot of variability across metropolitan Melbourne, but also across the state in terms of alcohol-related harms. And I certainly won't go into too much detail here, but you can certainly have a look in the report if you're interested. We also, as I said, map routinely at a postcode level, and this really gives us an opportunity to identify how alcohol-related harms and other drug-related harms are concentrated based on geographic location, and what might increase the risk of harm in some local areas as opposed to other local areas. And I didn't think it was really possible for us to be able to do this today without talking a little bit more about crystal methamphetamine related attendances, where we've seen these 2 years of substantial increases and the implications that that is going to have in terms of the provision of treatment, in terms of harms in the community, in terms of law enforcement, emergency service provision. And in 2011-12, what we saw is certainly a much lower rate of attendances in regional Victoria compared with metropolitan Melbourne. We saw a higher degree of alcohol involvement in crystal methamphetamine cases in regional Victoria when we look at metropolitan Melbourne as a comparison. But overall, not too many differences, a higher likelihood of transport to hospital, and again, a much lower likelihood of police co-involvement in these cases. And in terms of the change in metropolitan Melbourne in the characteristics of these patients from 10-11 to 11-12, we certainly saw a massive increase in terms of the number of cases being seen, and that's, I think, obvious when you see an 110% increase in 1 year. But we saw a significant reduction in alcohol involvement in these cases, which is certainly something that's encouraging. We've had some concern for quite some time about polydrug use and the implications that may have in people increasing their alcohol consumption and or their amphetamine consumption when they're having a big night out. And that reduction is certainly encouraging. However, it's not leading to a reduction in attendances overall. And largely we're seeing fairly similar trends across the other characteristics of these cases. So there's nothing specifically that stands out to suggest what might be driving this increase, a completely different population, for example. We are seeing some changes in transport to hospital and those factors as well, and certainly evidence from other sources and anecdotal evidence is leaning to the conclusion that we are potentially seeing higher risk populations and also populations of crystal methamphetamine users who may have been using for an extended period of time and so are increasing the risk of both acute and chronic harms associated with their consumption. And just to really highlight the increase that I'm just talking about, these are crystal methamphetamine related attendances from 2002-3 to 11-12. And so in the previous graphs, I just included all amphetamine related attendances. But as you can see here, this substantial increase over the past 2 years in attendances is of significant concern and certainly represents much higher numbers of cases than we saw in attendances and in other indicators of harm around 2007-2008, when there was certainly a strong degree of public concern around ice-related harms and a lot of public education and treatment initiatives to be able to address that. So it's really important that I just flag some of the limitations of this data and of this study. Every study has limitations. We can't do everything and cover everything that we might like to in any kind of study. We have to be limited in some capacity. So as I mentioned before, these data are not collected for research purposes, and so there may be some characteristics that we might be interested in but simply may not be collected or may not be reliable in the data. As I think it's quite logical, this data will exclude events where an ambulance service is not used or an alternate service is provided. And I'd just like to give a caveat of that. Even large events like music festivals, for example, where, say, St John's Ambulance or another service may be available at the scene for first aid, where patients are being transported to hospital, that tends to occur through ambulance, Victoria Ambulance. But we can't include cases, say, where a patient has had a significant event associated with their alcohol or other drug use and they've been transported to an emergency department or another medical service by family or friends, for example, called a taxi there. So we don't have every single case. However, we do have what we believe are the most acute cases, for example. So opportunities. This data is used in a number of different existing projects. We use this to inform the Drug Statistics Handbook, which we produce for the Department of Health, the Alcohol Statistics Series, and also the IDRS and EDRS. We provide secondary data to be able to support the primary data collection that's undertaken for those studies. As I mentioned before, we've undertaken data linkage, and it really represents a fantastic opportunity to be able to look at patient pathways through care, points where there may be scope for intervention and referral along that pathway from ambulance to ED to hospital, and identifying where patients actually drop out of services as well to be able to better target resources. It also allows us to better understand what's happening in the emergency department and in the hospital, because as I flagged previously, it's actually very difficult to identify those cases in those settings using data that's routinely collected. Linkage also gives us the capacity to explore outcomes and longer-term patient pathways through different systems as well, and to be able to see how interventions may actually improve patient outcomes in the longer term. We have the capacity to do time series analysis, so we have data for a lovely long time period now, but also because we receive individual cases, we actually have data on a daily basis, on a weekly, on a monthly, on a quarterly, and so we can actually look at patterns that may occur over the longer period of time. The capacity to explore alcohol and drug-related violence is something that we're very interested in. We're about to commence a project examining those issues and issues of alcohol and drug-related violence, both in the lead-up to paramedic attendance, during the attendance, and how that has implications for emergency services staff, including police who may co-attend, for the paramedics, and also outcome for the patient, and looking at that across different drug combinations and different drug groups and different contextual factors, so characteristics of the patient and characteristics of the event as well. And there's also capacity to explore both mental health and alcohol and drug issues across different care settings, and we're undertaking some feasibility work for the Commonwealth at the moment looking at overdose and suicidal behaviour, which is really exciting work to be doing with this data as well. So just to summarise and conclude, alcohol and other drug harms are very complex and they impact on individuals, their families, their friends, emergency services and the community more broadly. We need evidence-based approaches that are innovative and allow us to be able to respond to these issues in an effective way that improves the health of individuals and of communities and doesn't cause any unintended negative consequences. Monitoring emerging trends within and across populations is essential for the development of informed policy and interventions across different settings and across different services. Thank you all very much. You can contact me and access the report there.
Thanks very much, Belinda, for a really comprehensive overview. So we're open for questions.